Good afternoon, everyone, and a very warm welcome to Healthcare Improvement Scotland's webinar on medication reviews for older adults living with frailty. I know numbers are increasing as we speak, but we'll get started in the interest of time. As we've said in the chat box, this is going to be recorded so you can come back into it at any time. Next slide, thanks. So my name's Lara Mitchell. I'm the National Clinical Lead for Acute with Healthcare Improvement Scotland. Next slide, thanks. A bit about housekeeping. You all know how to function with Teams. Camera and mics off at the moment just for increasing that Wi-Fi capability. But please do use the emojis for the speakers when they finish speaking. Next slide. Any technical issues, get in touch with Gemma. Next slide. And as I've said, this is going to be recorded, and will be on our website within about a week, so people can duck into it. If you need to get away, you can watch this recording at any time. Next slide, thanks. So the aims of the next hour, and we're going to stick to time, are to hear some real live examples from two areas in Scotland about work that's been done in medication reviews in the older adult, to explore how medication reviews can improve outcomes, and consider how to improve the communication and coordination of medication reviews. Next slide. And the agenda for today is we're going to hear from Dumfries and Galloway and Moray, and we're going to have a chance for question and answer at the end to both our speakers. So at the end of both talks, we'll have a chance of Q&A. Please put all your questions in the chat box. So if you can start doing that during the talks, we'll pick them up and we'll try and theme them, and we'll do a quick evaluation and try and close on time. Next slide, thanks. So I'm a geriatrician, and that's bread and butter for me, looking at polypharmacy reviews when people come into hospital. And I actually saw it from the other side recently. My aunt has recently moved up to Scotland, and this will be no surprise to many of you on the call. These multiple pill packs with half of them missing, tablets that they didn't have the correct dosing, so it was switched to liquid, and it was just absolute chaos. So it's about those medication reviews, but it's about what happens in the community beyond that and how those pills are being taken. Next slide, thanks. So this is data, and I think it's always good to have a grasp of this when we're trying to influence and talk to other people from 2018 in the 7 Steps Polypharmacy Review. So 8.6 million unplanned hospital admissions due to adverse drug events in Europe per year, and that equates to 11%. A staggering 50% of these could be preventable. And we know from our work that 70% of these admissions are in people over 65 and on that crucial 5 or more medications. Next slide, thanks. And frailty is not binary, so it's a continuum. So what's right for one person may not be right for the other. And as you'll see from these pictures here, it's planning it with our patients, ensuring coordinated care. I love the picture on the bottom, so the confusion about which tablets to take. So ensuring that people are fully engaged and at the center of the process. And this is going to be brought to life by our 2 stories today. Next slide, thanks. So we know about the 7 Steps Polypharmacy Review, and I think our first speaker is going to talk to this, published in 2018. And the final slide, thanks. And I just wanted to highlight some really excellent work going on in GGC. So they recently published polypharmacy reviews in older adults living with frailty, particularly moderate to severe frailty. And they've developed this infographic. So I checked in with Leanne Black, who I think is on the call today. And I know Brenda was involved with this and 2 of our consultant geriatrician colleagues. So they've given a step-by-step, what is frailty, a bit about the CFS score, and then looked at it in terms of organs, so gastrointestinal, respiratory, etc., and giving lots of advice on stepwise different medications. So quite complex, but distilled into a really simple format. So It'd be good to hear about other pieces of work going on around Scotland, and Leanne is happy to share this because a lot of work went into having this developed. Okay, next slide. So moving on to our speakers, it gives me great pleasure to introduce Lucy Little, who's a lead clinical pharmacist from NHS Dumfries and Galloway, and Dumfries and Galloway are part of our Focus on Frailty programme. So really looking forward to hearing you speak, Lucy. And remember, before Lucy gets started, questions in the chat box, because I hope that we'll be able to have some really good discussion after both speakers.
So hello everybody, my name is Lucy Little and I am the lead cluster pharmacist in Annandale and Eskdale down in Dumfries and Galloway. So we've been completing a bit of work around realistic medication reviews with a focus on a patient-centred approach to managing polypharmacy in an ageing and frail population. So what matters to you? So you heard a wee bit there about the 7 steps of polypharmacy, and that what matters to you is really the leading question in any of that realistic medication review that we're undertaking. So the bit of a background here is that there was a recognition that the workload that we were undertaking as a team was becoming more and more reactive rather than scheduled and proactive. So we wanted to focus on that shift to that proactiveness to improve patient outcomes prior to problems arising. So not just reacting to it when there is a problem. So this situation has kind of arisen through a number of reasons. We have quite a rural and ageing population down in Annandale and Eskdale, with a lot of this patient not visible to the general practice team unless there is a problem arising. So what we kind of wanted to do was understand the patient's thoughts and what their expectations were around their medication, and address how to educate and inform patients and carers with the risk that there is around their medications, and with the hope that we are able to keep them living well at home for longer in a care setting that's appropriate to them. So we've got this wee infographic here with the star in the centre and the entire multidisciplinary team working to be part of that, with the patient at the heart of everything we do. So the background, again, going back to what was kind of said previously, there is a lot of national background to this. So we have the Polypharmacy Guidance and Realistic Prescribing from 2018 with the 7-step polypharmacy review. We have a lot of the CHURAS education work on shared decision making with the DECIDE and BRAND acronyms, and also your clinical screening tools such as your stop start when dealing with medication in ageing population. A wee bit of the local background was that we had some local success in medication reviews in our care home population, and that was the general practice team working, both our pharmacists and technicians in care homes, to optimise medication in a very patient-centred way and a realistic way. We obviously have pressures on health and social care at present, and as well as the acute services. So all of this is nothing revolutionary. It's just making sure that we're completing quality interventions and that the patient's at the centre of those decisions that we're making. If we are more organised, these decisions and this process tends to be more efficient, and actually the patient journey is far more improved. The key drivers. So realistic medication review is what we wanted to achieve. So we had to make sure that we were identifying the right person. So as we've kind of discussed, medication review is appropriate for and can be beneficial for everybody on repeat medications and who is taking medications, but it's trying to iron out who is our target cohorts and who is at the most risk of harm from their medications. Patients' involvement and shared decision making. So actually having that as at the forefront of our mind when we're approaching any of these medication reviews. some of the barriers here were ensuring that a patient had capacity or had somebody around them to help them empowered to make those decisions, but also touching on health literacy. Does the patient understand the information that we are giving them and what that means to them and how they can apply it to their own life? So access to service in an appropriate space. As we've mentioned there, we are quite a rural location, and the kind of cohort that we were targeting, the aging population or frail population, aren't always able to come into general practice and come into surgery space. So exploring home visits and the challenges associated with those. And also staff competence and training. So ensuring that our entire general practice pharmacy team were upskilled. So our pharmacy support workers, our technicians and our pharmacists completed training around the Rockwood Frailty Scale and understanding what that scale meant to application to medication, and our shared decision making, and also our realistic conversations, discussions and training that we had locally. So I mentioned there about identifying patients, because making sure that we're speaking to the right people and the people that are getting the most benefit from these discussions is key to this piece of work. So as we've kind of said previously, a lot of this was reactive. So once a problem had arisen, once we were at crisis point where the patient was suffering from harm, then obviously it's obvious we have to intervene with this patient. And again, post-discharge, frailty was identified by the autumn leaf at the top of the discharges that were coming through to us. So we wanted to move to a more scheduled and proactive approach. So the general practice pharmacy team could do this through coded searches and the use of the Scottish Therapeutic Utility Toolkit. The general practice team could do this through the eFrailty Index and also through chronic disease management. And the multidisciplinary team approach, so at those regular meetings, proactively highlighting patients who may be of benefit or meet some of the key drivers going forward for medication review. A lot of this proactive work did have a reliance on appropriate e-coding and access to wider electronic systems such as Bluebay and Spire. So that's something to bear in mind when we're approaching any of this work as well. You can see on the right of the screen that we had a priority thermometer. So again, kind of touching into the driving factors with the realistic medication review of frailty. So the higher the frailty score, the more urgent the medication review was. And number of items as polypharmacy increases. Predominant conditions, we've used dementia there. As dementia progresses, obviously the need for medication review, if that's not already happened, increases. But also a recognition of high-risk drugs or cumulative drug burden. Despite all of these, that may be the predominant driving factor. So the test of change happened through the summer months for an 8-week period and focused on medication reviews and outcomes. So did we ensure the reviews were patient-centred? So from reviewing all the data, 100% of patients or carers were engaged with reviews, and we established what their priorities were and what they wanted to get out of this medication review. So what were the clinical outcomes? Who did we touch and what happened as part of these reviews? So the average age was 73 years old. So again, an ageing population. 11% of used medications were deprescribed. So that doesn't include anything that was sitting to clear through housekeeping. These were used medications that were deprescribed. And 25% of these deprescribed medications had a high anticholinergic burden score. So who highlighted the patients for review? 90% of those were proactively highlighted by the pharmacy team through those search-driven tools, and 10% were organically from the wider multidisciplinary team. What was the main driving factor for these reviews? So unfortunately, frailty was not the main driving factor in identifying any of these reviews. So the outcomes. So this is a wee bit of a flavour of what we tend to experience as part of these reviews. So some key themes kind of illustrated in a couple of examples. So patient A was a 78-year-old female. And what did she want? She wanted to live at home independently. She didn't want admission to hospital. She didn't want carers. She didn't want family members to be a burden on them. So we looked at her medication and she had a high anticholinergic burden. So we reduced her or stopped her oxybutynin. Her amitriptyline continued, but there was an acknowledgement there and a risk reduction conversation of actually we maybe need to review your pain ongoing and a plan to make those reviews and the reductions. Also, cocodamol was reduced to reduce the amount of sedation she was currently experiencing. Again, it's a full medication review, so we're not just focusing on the high risk things. We had a wee discussion on topical steroid education and a focus on emollient use to prevent flares. And she also had a physio self-referral. Patient B was an 81-year-old female and she was really struggling to swallow her tablets. She didn't want to take as many tablets as she was, and she was feeling they were getting stuck. So we had discussions around anything clinical and also how we could reduce some of her tablet burden. So our bisphosphonate was stopped. We had a discussion around NSAIDs, so the lowest dose for the shortest period of time, and reduced these with a follow-up review. Her paracetamol tablets were also switched to suspension. Again, using this as a very good opportunity to discuss sick day rules and make sure the patient is educated on risk of potential harm, as well as she had a referral for a DEXA scan in line with the Dumfries and Galloway protocol. So again, it's quite difficult to identify what the long-term benefits or the if harm would have come to these patients, but we did get some feedback from patients regarding what they felt their experience was of these reviews. So this was really helpful. I didn't know this service existed and no one has ever gone through all of my medicine with me before. So patients, it was a very positive experience for them to have that dedicated time to go through with a pharmacist or a technician what all their medications were for, how they were using it, and then understand what mattered to them, and as a result make appropriate medication changes or implement that education so that the patient was more informed and more aware of what was happening, and for them to also have the support of maybe chaperones or family members or friends round about them to support and enable them to get the most out of these consultations. So next steps. So we continue with local engagement and external engagement sessions in the locality. And we really want to work as that wider multidisciplinary team across sectors as well to focus on these at-risk cohorts. So making sure the most at-risk people and the most vulnerable people in our communities are able to access these medication reviews in a timely manner. So again, not wait until there is problems arising before they're brought to our attention, proactively engaging with them. One of the steps that we thought would be a really good positive way to go forward with is community pharmacy education. So again, community pharmacy sees a whole host of patients on a daily basis or their family members, and can have those organic discussions of what's maybe not going so well with their medication or concerns they may have. So again, community pharmacy would be a prime team to have some education on frailty and what that means and how that's applied to medication management and harm reduction, but also awareness of referral pathways into the general practice team to be able to complete those medication reviews. Our second point here is the kind of challenge to be able to use frailty as a reliable, consistent tool to identify these reviews, or to have that as the predominant driving factor. So the wider multidisciplinary team have agreed on the Rockwood score as something that will be used across Dumfries and Galloway, but where it's not currently a usable tool is that it's not consistently recorded. So it's there and it's in the baby steps of moving forward, but actually that local agreement of where that information is going to be be recorded so that we can use that and other teams can also see that. So it's, again, a very organised and structured kind of approach. And then the third point is something that we're going to engage with Healthcare Improvement Scotland a wee bit more on. So the individual impact and intervention. So difficulty in measuring the harm reduction or improved outcomes. So we've obviously reduced some medications and we've deprescribed medications that we know have the potential to be harmful, but how do we measure that going forward? So that's something we're going to take a bit more engagement on. And that is me.
Thank you so much, Lucy. I was so busy trying to get my react and sense of applause. You can see it down there. Lots of applauses, which is lovely to see. Presenting your really person-centered approach to polypharmacy reviews. So we're going to move straight on, but we're going to come back to you. There are so many really good questions in the chat box, Lucy. You may want to have a quick look at them because I'll obviously be asking you after. But on to our next speaker. So next slide. We're just handing over. So great. Christine, have you got control?
Yes, I do now. Yes,
great.
Thank you.
So going from one end of the country to another, really looking forward to hearing what Christine's got to share with us from NHS Grampian, and she's the lead pharmacist for primary care there.
Hi, I'm Christine. Yeah, and also on the call, I've got Elaine McIntosh as well. And I would like to, Elaine's one of the senior 80 pharmacists working with me in Moray, and also like to acknowledge Craig, who helped us with the data for this project. So basically, I would like to describe to you a project for medication review that was completed by our team in Moray Pharmacotherapy within the care at home patient cohort mainly. So a bit of background. So patients were on, lots of patients on medicines management. That was ranging from some just having prompting, some having a full level 3, some as part of a package. But what was common was that there was a general lack of medication review. So we started to think, what is required long term as for review? And is there an opportunity here to review medicines prior to allocating and aligning a care medication package, a care package, if we could look at the medication first? So our aim became that we would take the opportunity for an upstream approach to the medication review, and we hope that this would assist towards perhaps reducing the time required in visits to the patient, or perhaps reducing the frequency or even the number of visits to the patients. We employed 2 different methods. The first method was actually designed by Craig, and we had a little electronic link. It was part of Microsoft Teams that it linked to, and this link received in referrals from all different, whether carers themselves or their managers or social work, etc. The referrals for the patients to be med reviewed came in through the electronic link. They were then apportioned by myself most geographically to the correct practice pharmacist, and the medication review was done with the patient, and then following that, all the changes and the information was referred back to the original referrer, and of course populates the spreadsheet on the Microsoft Forms. So it was quite a swift approach. The second method, after DPIA approval, which did take time, we managed to get a wee list of some patients that were on medication management review. And we also did a similar process, but it was from the list. So again, the patient would be pointed to the correct pharmacist geographically, and the review would be done and the information fed back as well as populating the spreadsheet. So what results did we achieve? So we had 128 patients on the first process, which was the individual referral link. And we managed to make medication changes in 42% of these reviews, some small and some bigger. So in 22 patients, we stopped at least one med. And in 36 of the reviews, we managed to reduce the frequency of the dosing. So the pharmacist medication review reduced the need actually for 48 daily visits in total. And lots of factors there at the end of the slide preventing, change to the visits or the frequency. So the next group results was the list that we had received. 16 of these patients, and then we managed to stop at least one medication. And 13, we managed to reduce the frequency of the dosing. And you can see in the wee coloured slide there, the blue is before the project and the yellow is afterwards. So you can see it's starting to come down, the patients that are requiring more visits. And on top of that, we had also 12 that still required their visit for other aspects, but didn't require for medication. And in 22%, we did find it difficult with those that were on the regular analgesia. Adding the two methods together, we looked at, okay, so how many meds were stopped? So we did 200 in total med reviews and gathered the data, and 39 patients stopped at least one medication. And in total, 68 medications were stopped. You can see on the graph there how many medications were stopped. And what about the potential visits that we wondered if we could reduce? So on 51 of the medication reviews, we stopped at least one daily visit. On 74 potential total medication visits could be stopped per day. And extrapolating that to weekly, we reckon 519 weekly visits could be stopped weekly. So what discussions did we have during the project? And that was with relatives, patients, the wider multidisciplinary team at the GP practice, because our staff are all embedded in the GP practices. And as well, we had to go to a hospital and the local pharmacy sometimes as well. So what actions were actually taken during the review, and we've put on the slide there, plain med review, but also maybe reducing the med stopping, but identifying relatives to discuss with and maybe stopping or changing timing, swapping over to something else, medication that would be therapeutically equivalent. Lots of discussions. Yeah, you can see it there in compliance issues, lots. So to move on, so I've mentioned already that the analgesia frequency was a bit of a problem always in the patients to reduce. So on this slide, you can see the purple. In 28 patients, it was really difficult to change anything as regards their analgesia or their visits. But on the orange at the side, we found that 4 were able to be changed to PRN, and on the other side, we had 5 changed to a reduced dosing, and then also some titrating downwards, and also some stopped. And in 3, the analgesia wasn't the primary issue for the patient requiring the medication support. So other factors, as well as the analgesia, there's other factors preventing review, and in some we couldn't go any further. Some had to agree with the specialist input, and some patients were already self-administering or starting to involve the family. There was quite a variety, really. And what were the reasons for the referral being received at the outset? And you can see down the side quite a variety of different reasons that we were receiving the referrals of the patients, and lots of different groups forwarding on a referral. So The majority of patients, as we've said, had no recent med review, and that was one of the reasons for the piece of work. In 62% of the reviews, we found that they were most successful because they involved a lot of discussion and a lot of communication. And this would be with the multidisciplinary team, the patients, the carers, the family. And there was a real opportunity to discuss and get some buy-in from the family members who this had been overlooked, and they were really keen to be involved. And we also managed to identify some shorter visits that didn't require the whole time as well. So as general outcome themes, I think we must say that we reduced the tablet burden for the patients, but we showed that medication could be streamlined in the patients. So discussion, yeah, so we did spend time, all the pharmacists, talking with a multidisciplinary team, which was very, very valuable. And who were they? Well, they would be the dementia nurse, the GP, the ANP, the district nurse, a great variety. And we had some exclusions there as well, palliative, or those patients that were perhaps in the process of moving on to care home were excluded. So what did the team actually do? I've just included 3 quick examples of what was actually done on the ground. So the first example was a referral from a frail patient who was receiving twice-a-day visits. And you can see that the pharmacist concerned changed the calcium from twice a day to once a day. The patient was also having a twice-a-weekly visit to support with a pessary insertion, and that could be stopped. The patient was quite happy, and that stopped that requirement. The patient also was very keen to use their own emollient rather than the one that was prescribed, and there was no specific dermatological condition coded, so that made sense. We updated the bloods, also looked at family support and discussed, and the outcome was that we reduced this patient to once a day instead of the twice a day. The next example we have here is a referral of a patient to the pharmacist on multi-meds, many for blood pressure. So the bloods required updating, so the bloods were updated and the results examined, and the blood pressure was also taken sitting and standing. Again, after looking and discussing with a multidisciplinary team, the hypertension medication was actually all stopped. There was a bit of high postural hypotension, and the medicines were not required, and they were stopped. And the HbA1c came back low, so the metformin was deemed to not be required, no longer indicated. Also, as was the iron, the hematinics and the iron was examined in the bloods, and there was no continuing need for iron supplementation. So again, this was very positive, and the outcome was that there was no visits required for this particular patient. And my final example for you, this was a patient that was on lots of meds in the morning and only one later in the day. And the one that was on later in the day was apixaban, the patient's DOAC. So basically what was done, a lot of discussion with the daughter who had power of attorney. The apixaban was twice a day, but we discussed changing to rivaroxaban, which is a once a day DOAC preparation. This was absolutely fine once it was explained. So the later in the day visit was stopped, and this patient only required once a day visit. So what did we find as the constraints? And yeah, we have to be honest, the pharmacy capacity within the pharmacotherapy team in Moray was definitely a constraint, and the capacity is tight. The referral rate was low and slow, and in some ways that was quite good, but it was a constraint for getting through, a fair number of patients, which we felt we were going to require for the data collection. We did also find, to be honest, that the GP files, not everything was coded according to, there was very little information as to what care input the patient had or what was required or the frailty state of the patient, the condition. Yeah, and we also found it difficult to contact the patient in some occasions. So what does this mean for the future? What quality improvement could we look for? I think we need to definitely ensure that there's a culture of medication review at the outset of any care planning for a package and aligning as regards for the medication support. And I think as well as doing the medication review at the outset, it would be really good to do follow-up medication review with the patients. And I think getting the correct list, similar to what Lucy was saying, we need to know, we need to have the right high risk patients and patients that there's an urgent need for the care. That would be the ones that we would want to prioritise and moving forward. And we would be open to discussing and training care staff. That's something we haven't really done, although we've had meetings with them. I think we could do more there, and more involvement of the patients themselves and the families as well. So looking to the future, I'm sure there's lots that we can do as well, maybe some better systems and maybe some electronic prompting. And, you know, does the carer actually need to go into the patient's home each time? So yeah, so that's all my slides. Thank you so much for listening, and thanks for the opportunity to share what we're doing in Moray. Thank you.
Lots of applause there, Christine. Thank you to both our speakers, Christine and Lucy, for sharing their stories where they work about these new services. Now, I've got to say the chat box has been very active. I've got quite a lot of questions for both speakers. I would also like to highlight that there's been a number of really excellent links popped on the chat box, which maybe we can share around. Leanne shared the GGC image and what lies behind that. There's sick day rules on there, so please have a look at that. Yeah, and lots of positive works, and thanks to both speakers. So questions. Firstly, Lucy, can I start with you? There was a bit about training of the Rockwood. How did you train staff? There has been a link to training popped on the chat box, but really interested about how practically you did that training, and also training about realistic conversations.
Yep, so the Rockwood, everybody was encouraged to do the e-learning. So, I mean, if the link's there, we can circulate that. It's quite a simple, very user-friendly, and applies to every role in the pharmacy team. It's quite basic. We also have clinical discussions on a regular basis. So we have a monthly locality huddle, and that formed the basis of one of our conversations. So again, we had pharmacists, technicians, pharmacy support workers around, and we actually work in the same building as the home teams, which is a multidisciplinary team of social work, district nurses, occupational therapists, etc. It's basically just a liaison team. So we had discussions with them as well, and invited them along who identify frailty, so and code for that. We made the decision locally that we weren't going to be the ones identifying frailty. Our skill set wasn't best set to that, but actually to understand what frailty meant for our patients and what this score meant was more important than assessing for frailty. So again, just that kind of realistic conversations and that team peer support after that formal training to make it a bit more applicable in a day-to-day setting. And the realistic conversation training is all on TURAS. So if you have a wee look on TURAS, everybody did that module, as well as kind of having those, everybody bring in a realistic discussion. So an example that they've maybe faced in their working week. So our pharmacists are encouraged to do that anyway, there might be some ethical dilemma in there that they've faced, or something new clinically that they're facing for the first time. And that shared real learning is a really valuable tool that we've used to upskill the entire team.
Brilliant. So yeah, a combination of modules and ongoing learning and support. Fab. There was a wee thing about your autumn leaf icon. So somebody had asked what it was. It's your frailty icon that you use. I was just intrigued to know, is there a certain CFS that then that's applied for? What's at the back of that?
I'm not sure, so that's something I need to do a wee bit more digging into. But just locally, the autumn leaf has been an identifier from coming from the acute setting that will be on there. I don't know what coding is exactly, or identifier kind of pushes that along or drives that, but it is there.
Okay, good. Thank you for that. I'm going to go back and forward. And have you got anything to add to that about education, Christine, from your team? Because one of the questions actually that's similar to that, somebody's asked, can we make more of the pharmacy technicians and support workers to augment this service? And I suppose that's to do with the training. So can you bring that in?
Yeah, I'm sure that's a really good point, but I have to be totally honest and frank that it's the capacity that would be the issue here. But we have created some voiced over presentations and that type of thing that can be used very easily remotely by different carers, etc. So yeah, we've done a little bit, but it's an area that we could maybe do more, but it would require some support time.
Okay. Christine, a few people have been asking, I had a couple of questions about your referral. What's the method behind your referral? I know in NHS GGC they've tried to use it on Teams, I think, Leanne. So how did your actual pathway work? What are the logistics?
So it's an actual link. So it just appears as any link, and you just click on the link, and it's a Microsoft Forms. So you fill in the details, and it's very efficient, very easy, user-friendly. You just fill in the bare details that's asked for, and then that comes back to Craig and myself automatically, and we then decide, okay, what practice is that patient, geographically, and that is passed then on electronically to the pharmacist, and all the details follow with it, and it also just automatically populates an Excel spreadsheet as well because it's Microsoft Forms.
Great. Okay, I see there's a few comments in there that some people can't use MSF Teams because of patient identifiable information. So I suppose it's got to be tailored about what works for you within your health board.
Yeah, it's Microsoft Forms.
Yours is Microsoft Forms, yeah. Okay, that's good. Now, can I just ask, do you have any problems with using Microsoft Forms?
So we don't use Microsoft Forms. We use our generic email, our NHS email, and so where we were different from Christine in that those forms come into our generic email and are triaged by our pharmacy support workers up the way. So it's managed by our pharmacy support workers, and then are triaged up to either a technician or a pharmacist or a hub pharmacist as to who deals with that medication review. So slightly different perspective that we don't use forms. But obviously, Christine, have you run into any problems?
Yeah, I think the key thing is just ensuring the governance is around the process has been agreed with all key stakeholders there, and it may differ depending on which board. Can I move on to your cases, because there was quite a lot of questions around the cases, and it was brilliant that brought that to life. So Lucy, we'll go to you first. There was a little bit questions around, did you give alternatives to the oxybutynin for I think it was the first lady? How do you feed into her Foles assessment review, or are you actually doing this? Are you able to comment on that?
So the oxybutynin in this case, it'd been something she'd been on a long time. So she had been on that medication and it hadn't been reviewed for a very long time. So actually, after discussion with the patient, she didn't really know if it was having any impact or not. So we decided to trial stopping that with a follow-up kind of review to see if there was any difference in her urinary symptoms. And in this case, there wasn't. She felt like she didn't want to take another medication. She didn't want to explore other options with a less anticholinergic burden, and actually felt like she was okay in herself. So again, listen to what the patient's kind of expectations were around that, and presented a couple of options to her. So, and allowed her to she was quite an informed lady and quite a proactive lady. So she wanted to have those opinions and move forward with that. With terms of the falls risk, we did work as part of the multidisciplinary teams I mentioned there about our homes team. So we have the physios, we have the occupational therapists, we have social work, etc., all as part of that home team. And working so closely with them has fostered some really good working relationships. So you can chap on their door, you can send them a wee Teams message and say X, Y, and Z. Can we have a discussion? And that then flagged the patient to their radar, and we're able to go out and assess and support the patient with some local resource as well. So again, it's common sense thinking and just joined up working to make sure that we're getting the best for the patient. And just, you don't have to be a master of everything, but recognizing who you can lean on for support to aid you to make the patient journey as easy as possible.
Brilliant. Thank you, Lucy. And some questions around the cases that you presented, Christine, was really around if you're stopping blood pressure medications, what's the process for review? I mean, I run a blackout clinic, so this issue with hypertension and orthostatic hypertension is a massively complex issue. So how do you follow up that blood pressure? What's the process for that? And the bloods, do you recheck bloods? What's kind of your follow-up for when you've altered meds?
So I think Elaine's maybe going to come and answer that one.
Great, Elaine, welcome.
Current.
Hello. Hi. What we would normally we have a process in most of my practices anyway. When we've stopped somebody elderly, frail, this lady in particular was one of mine. So what we discussed with the daughter, who was power of attorney, she had access to a home blood pressure monitor, so we kind of set it up with her to do a regular kind of weekly thing, and at what level to get in contact with us. What we've done for other patients when we've stopped ones, if they're housebound, we'll maybe ask the district nurse team in 3 months to do that. If not, we've got a really we use an awful lot of self-electronic messaging in our systems, so to try and simplify things as possible. So it'll ping up a reminder for us to invite somebody in for a blood pressure or bloods or anything sort of 3 months after stopping. So we try and kind of put into the system a way of following up so that we don't lose them completely, just to make sure that what we've done is appropriate and ongoing, that there's no issues at the end of it. So we've got, as Christine said, all the pharmacists are embedded with the multidisciplinary teams in practice anyway. So we're quite lucky with my large practice. We've got social work, we've got the district nurse team, our practice nurses, our frailty nurse as well, and mental health nursing, so as well as ourselves. So, and that's a weekly thing. So we're quite proactive in what we do.
Brilliant. Thank you so much.
Okay.
And the reduction in home visits is for medicine prompting is really impressive about how we can just save that resource by working smarter. And we're running out of time, so I really want to lean on your expertise, all of you, and ask for one top tip to improve communication around the coordination of medicine reviews. What's the one thing that looking back you would say to yourself now that then other people can get on and do? So if each of you want to go, do you want to go first, Lucy?
Yes, I'll jump in. I think not presuming that a patient is health literate. So don't just presume that a person understands what you mean and doesn't need that chaperone or support from maybe family or friends round about them. So always offering that as we're arranging the medication review. Actually, when we've had elderly or frail patients with a family member there who maybe helps to manage medication anyway, they've been able to retain information that maybe the patient hasn't been able to, and apply that to the whole situation because they understand the situation a wee bit more. So that not presuming health literacy, I think, was
Brilliant.
the number one.
Great, thank you. Elaine, what's your top tip?
I'm very much for use the electronics and the expertise of those that know how to use them. Craig in particular has just been an absolute amazing person to work with in this. And I think more so than anything, to change the focus of not just doing the polypharmacy 7 steps, but also to consider the social side of it, what we've actually got available, sort of time-wise, whether it's family that need to kind of step up a little bit now and again to help, or what visits we do actually have available, and see where the focus is there. Can we change anything? So
brilliant. Thank you, Elaine. And Christine?
And yeah, just to add, I think involve the multidisciplinary team, because it can be very resourceful, and often they'll just say, oh yeah, I know that patient really well. But I think most importantly is involve the pharmacist throughout the project. Sometimes I would be told by the care manager, oh, they've had their med review, but we hadn't caught sight of that patient. So I think we go deeper, and I think we can be resourceful. If it's maybe, you know, a therapeutically equivalent medication, it might be once a day rather than twice that we highlighted, that type of thing. I think we can be quite resourceful, whereas with the greatest respect, a nurse might not realise that not all DOACs are once a day or twice a day. So I think just, yeah, I think involve the pharmacist and we go that wee bit deeper. Thank you.
Fantastic. So the 3 things coming across there are don't presume health literacy in our patients. The second thing was just use what's around you, use digital technology. And actually you couldn't predict this, Elaine. When you were speaking, somebody popped in the chat box, use Alexa for medicine prompting.
Yeah.
At the exact same time. So I hadn't heard of that, so that's fantastic. And then the third thing is work as an MDT, lean on each other and use our pharmacists. So that was just a fantastic learning session. I really want to thank all 3 speakers. I know you didn't present, Elaine, but your input's been fabulous in this conversation here. So big round of applause for all 3. Thank you for your time. And yes, there's so many links in the chat box there. So what we'll try and do, we'll speak to the HIS team about trying to distill them out and put them in an easy format so that you can come back to get them. Thanks also to Leanne Black for sending me her GGC. There's lots of things coming in. Before you go, please don't go. We're going to do a quick evaluation. So if you could just, it's going to take you 2 minutes just to click on the link here, just do it on the screen. So 1, how useful was this to hear about good practice? And I think you can scroll through at your own pace. Just type in what's your key takeaway from the webinar today. You can just scroll through this at your own pace. And the results are not shared. So please take the time to do this because it will just help us going forward. So I see number 4 is, would you like to be added to the HIS frailty learning system? So if you're not added, you'll really be missing out in Scotland. We've gone from 600 members to about 1,400 members across Scotland, which is an incredibly powerful learning system. So please share that with your colleagues. You've got access to all of these incredible webinars. Oh, 1,800. That's gone up in the last. Wow. Okay, this has been growing exponentially. So have we got a closing out slide, Gemma?
No, that's us today.
That is us today. We've finished just before time. Gemma, you've popped out in the next webinar of interest. Scotland Leads the Way, Pioneering Brain Health and Dementia Prevention webinar on Wednesday, the 9th of October. So let's have one round of applause. Thank you to all our speakers and to the HIS team for organising this webinar and the learning points.